Uh, Good morning, everyone. So today, uh, going over cardiac emergencies, just hodgepodge of stuff. Like everything else, we'll do our kind of review things, anatomy, physiology, blood vessels, all that stuff, to get the ball rolling. And then we'll talk about the whole laundry list of stuff. Any questions, of course, always ask. Typical disclaimer, like everything else, you guys are part of us as doctors. You might be saving my family's life. And if I miss things today, I apologize. I had a 15-month-old and or a 5-month-old and an 18-month-old screaming, so not much sleep. What? Yeah, exactly. No, that's that's working third shift. Can't help you there. All right. Remember everything in regards to the anatomy that we'll be going through. The heart and all that stuff is really the a motor of a car and all that stuff. So you have both the mechanical side of it and the electrical side. Um, so from there on the mechanical side, that does the majority of the work, 65% of things versus the electrical side, which all of your squiggly lines. Of course, we're not going to really talk much about that. Going back to heart anatomy, I think we've done this multiple times before. Okay, so the parts, the top part of the heart is the okay, bottom part is the okay. What's the most important part of the ventricle? Left or right? Left. Okay, that's the one that does all the work. Especially when we talk a little bit later with LVH and heart failure and all that stuff. Cone shape, just as a reminder, size of your fist, located a little bit to the left of the sternum. And then from there, 2/3 of again, the aspect of the past the midline. So when you're doing chest compressions and all that stuff, um, pushing it on the sternum, of course, does the ideal thing. But if you can even go a little bit to the left side, and that would work just as well. Left and right separated by the septum. This is your septum here. You have an atrial septal and a ventricular septum. That's the old ASDs and VSDs. So in kids, if they have holes in the heart, septal defect versus ventral septal defect, usually they all that get repaired. All right. So blood flow and all that stuff. So where does the blood come from? If it's coming from the brain, it comes to the superior vena cava, coming from the feet. Okay, so inferior vena cava goes into the right atrium. Okay, then it goes to the tricuspid. I really do need to put diagrams on here. Uh, exactly. I need to fix this up a little bit. So tricuspid, just remember, it has three valves or three cusps. With it has the papillary muscles and all that stuff, or the chordae tendineae is the other medical term for these little fibrous bands and all that stuff. That goes through the pulmonary, semilunar, up into the pulmonary arteries. Um, Oxygenated, deoxygenated. Yep, correct. Yep, come deoxygenated and then comes back oxygenated into the atriums, through the bicuspid, into the left ventricle, and then out through the aortic semilunar, and then down. Just remember from the semilunar valves, from the aspect, they look like little Mercedes-Benz signs. All right, and they stop the flow of blood coming back into the heart, either from the lungs on the pulmonic side, or from the aorta on um, the system side. On the with the aortic semilunar valve, I don't remember. Um, there's two little blood vessels, which would be the coronaries. So the entryway to the blood vessels to the heart is actually underneath of the aortic semilunar valve, and that's how the heart gets its blood. So when these things become calcified, they don't open, or they can actually become stiff, and they can occlude their arteries, which in turn can cause problems with getting blood to the heart itself. Some large veins, you have your four pulmonary veins, and then the superior inferior vena cava, and then the coronary sinus, which on the back side of the heart, like jumps into the right atrium. That's all the blood from the heart is collected back to the coronary sinus. We're just pushing quickly through this. Two arteries, that's the major ones. Either your aorta or the pulmonary trunk, and then from there, the right and left coronary arteries, like I talked about, are on the aorta, just beyond the your aortic semilunar valve. So semilunar valve, right there, coronary arteries will take off. So which one's the major side, the left or right coronary arteries? Question I never asked before. Woohoo! Yeah, why? Well, the coronary arteries, both of those will deliver oxygenated blood. Is the left coronary artery or the right coronary artery the major? Okay, but the left coronary, yes, the left coronary is the major one, and the reason why is it predominantly does the left side of the heart. It does the septal wall in the left side of the heart. Correct. Exactly. So it does the supplies the left side. The right coronary artery, though, is still important because that usually does the supplies the blood to the pacemaker of the heart. So if you knock off your right coronary, the person has problems with their pacemaker, which in turn cause all their funny arrhythmias and all that stuff. We don't really talk that much about that. Okay. So blood flow again enters the right atrium, goes to the superior and from the superior and inferior vena cavas or the coronary sinus. Don't forget about the coronary sinus. Ventricles push the blood out, goes to the valves, goes into the pulmonary trunk, into the lungs, and then ultimately comes back through the pulmonary veins into the atrium. Left atrium kind of sort of contracts and it fills the ventricle, and the ventricle pushes and it goes all the way out. Um, the problem with atrial fibrillation is that the atriums, the top parts, don't fire or work properly. So there's something that's called atrial kick that you lose, and that's where the atriums that does the last 10 to 15% of our ejection fraction is coming actually from the atrium squeezing down and pushing the blood down. So that's one of the why people with atrial fibrillation, all that stuff, pass out sometimes and they just don't feel well. Blood supplies, again, the left coronary does about 85% of the blood to the myocardium. That's the major side. The right coronary does everything else. But usually, again, the right coronary does the pacemaker of the heart, which is the major thing. And it comes from little valves right after the start of the where the aorta kind of sort of takes off. Divides the two major parts of the division, the LAD, okay, and the other name for the LAD is, yep, Widowmaker. Why is that? Yep, correct. And predominantly males are the weaker sex, so we die earlier than females. So marriages, sometimes it is the death part, as they say on Jeff Dunham. It's a goal that we're shooting for at times. um, but no, that's from the aspect of the LAD is the one that does the septum. You knock off the septal wall, patients die. They can't do anything. And then the left circ does the lateral and posterior sides of the heart, along with a little bit of the right ventricle. Coronaries, again, the right coronaries does the right atrium, a little bit of the right ventricle, and then from there, some of the aspect of the left ventricular side of it too. And like everything else, you have what's called anastomosis, or the blood vessels kind of sort of are built together, or through capillaries and all that stuff, so they're connected. So this is how we get the collateral blood flow, or if you knock off the left side, you can actually get blood flow backwards through the heart and all that stuff. So always important, especially when the patient goes unresponsive with CPR and all that stuff, that we can maintain their perfusion and all that stuff. Capillaries, like everything else, they just help with the transportation of the blood. And then ultimately, the coronary sinuses is the major vein of the heart that drains myocardium. All right. Question on anatomy of the heart? All right. So, what is the purposes of the arteries and arterioles? Transport blood. Okay, so go that. So they're the conducting side. Remember about the interstate highway that we talked about before. And then the venous side is to what? Branch off, collect. But the venous side, that's, if you guys remember, what's the major importance with the venous side? It is deoxygenated, but the blood vessels themselves, why are they important? Hmm. Okay, guys, and this is why we review. Okay, so the venous, remember, is the parking lots. They're the driveways. So that's where the blood sits. So the arteries and all that stuff is the interstate, and then you have all the roads that goes off the interstate, and then all of our driveways is kind of sort of what the venous system is. So the more all of our cars park in our driveways and parking lots. So they say in theory, 50 to 70% of your blood is actually in the venous side. So when we talk about later with CHF, when we do the review with that, treatment-wise, is when we talk about preload again, the cardiac output, which you so much love. All right. So the conducting side, the arteries are large elastics. The distributing arteries are your smaller ones. And then, of course, the arterioles are the smallest. So artery, the aorta is the big conducting, then going down in size and all that stuff. Capillaries, of course, the whole purpose of that is to allow one blood vessel to go through at a time. Sorry, one blood cell to go through at a time. And then it allows for the um, perfusion or the diffusion of oxygen and nutrients and collecting carbon dioxide and all that stuff. Veins, they collect all the blood back. The venules, some of the nutrients still do cross across in the venule side, but it's predominantly more in the on the capillaries and all that stuff. And then the veins coming back, different sizes, just like the aorta. But the big thing with the veins and all that stuff is they have the valves, because they don't have the ability to really push down and contract and force the blood back or forward. So the purpose of the veins, of course, with the valves, is to stop the blood flow coming backwards. Okay. So output is what? What's the two pieces for cardiac output? Stroke volume and Yep, cardiac output equals stroke volume times net. So what do we always, what are our vital signs? What do we check? The blood pressure. Okay, so it kind of sort of gets us with our stroke volumes and all that stuff. And we usually check pulse. All right. So your heart rate times stroke volume is your cardiac output. And then stroke volume, again, is developed into three different things. Your preload, which is how much blood the heart sees coming back. Then the contractility is how well the heart pushes or contracts itself. And the afterload, which is the amount of pressure that the heart sees. So after it contracts, it's the aorta pushes, or the amount of pressure that it pushes back. Again, these three things are important when we talk about congestive heart failure or with hypertension leading to congestive heart failure. That's the ejection fraction is your stroke volume. Well, stroke volume is a specific amount, but the ejection fraction is how much is actually being pushed out. But when they say 60% EF, is 60% of the blood, which is usually 85 mLs, is being pushed out. The rest does come back into the heart. Yep. And that's bad. Anything under 20 is usually dead. Case in point. So on the electrical side of it, the myocardial cells have what's called automaticity, or they have an inherent ability to fire. They allow electricity to run through them. They are just nervous system and all that stuff. So they have both the ability to contract and also allow electricity to go through it. On the other aspect, there's really two different types of pumps inside the heart. So you have the big pump, the heart itself, and then you have two little ones. The left side is the major. It really contracts down and forces the blood through, versus the right side, which is the low pressure pump, which blood actually more passively moves to the right side. All right. So on the cardiac cycle and all that stuff, systole versus diastole. What is systole? What preload's important with systole? Yep. What specifically is systole? Systole. What is the point of systole? Correct. Asystole is yes. Okay. So asystole is dead, which means nothing is working or contracting. Okay. So in systole, systole is contraction versus diastole is relaxation. Right. So during atrial systole, okay, so again, the blood preload coming back into the atriums, both from the venous side and then from the pulmonary, goes into the atria. And the majority, 75% of systole is it's just actually a relaxed period that the blood passively flows from the right atrium and left atrium into the ventricles, and then the atriums contract, pushing the blood. That again, that's that atrial kick, which is that last 15-20% of your cardiac output of the blood going into the atriums. Then they relax, the valves close, and then you have ventricular systole. So the valves close, stops the blood from going backwards. actually they slam shut, and that's how we get the lub. The first part of the lub dub is when you have the closures of your mitral and tricuspid valves, and then the aortic and the pulmonic, the aortic and the pulmonic semilunar valves open up, and the blood is squeezed out of the ventricles. Starts from the bottom and it works its way up, and that's how the electrical activity comes down the septum, hits the bottom, and then it works its way back up again. Our nervous system does do some things. Are the two major hormones of the body what? For controlling things. So the fight or flight hormone is adrenaline or epinephrine, and the rest and digest hormone. Well, insulin's part of it, but your acetylcholine. What? Well, beer acts like acetylcholine to a point. It has. I'll give you that. Yeah, but acetylcholine is the rest and digest and all that stuff. So nervous system again, atrial supplied by the sympathetic, and it does have some of the parasympathetic fibers, which is the acetylcholine. So our brain kind of sort of calm things or slow things down just by that aspect. And the ventricles is predominantly just sympathetic nervous system. You have the postganglionic nerve of the heart, which release the norepinephrine, which in turn that activates all of the sympathetic sides. And then the other aspect too with the sympathetics, the vasoconstriction. So someone gets scared, what happens to them? What do they look like? They become pale. That's why, because the blood vessels constrict down. Exactly. All right. And then from there, the heart-wise, the coronary arteries and all that stuff, epinephrine causes vasodilation, very similar to the nitroglycerin and all that stuff. Chemicals that they work together. Norepinephrine, of course, works on the alpha and beta receptors, and then you get a whole bunch of beta 1s with the pacemaker of the heart, and that's how it directly affects the heart rate. If you throw a whole bunch of epinephrine at it, or if you guys give albuterol, what is albuterol? Aerosolized epi, basically. Okay. So if you think about from that aspect, what do the patients look like when you start giving them a whole bunch of epi? Become anxious. They can become heart rate goes up. That's the tachycardia side of it. Exactly. They become diaphoretic, sweaty, and all that stuff. Okay. So using the things that you guys know chemical wise, going through everything else. Parasympathetics, this is all through the vagus nerve, the 10th cranial nerve. So on kids or adults or people like that, if you gag somebody, it's to their heart rate. But yeah, it slows down. Yeah, so they had the whole vagal or the vagal maneuver. You rub their neck, do a carotid massage. You have them bear down. If they have a fast heart rate, you're trying to do all the vagal stimulations and all that stuff. Or for kids with fast heart rates, take the kid, flip them upside down, and shake them. Yep. Yeah. Sometimes works. Yeah. Yeah. It does work. I've had it happen before. From there, the other aspect, going back into the adrenal glands, which are the little glands that sit on top of the kidneys. Basically, they look like toupees, or a very bad toupee, or the French berets. Um, and they release from the medullas. They have the norepinephrine and epinephrine. So you both have both the chemical side, which is the epinephrine and the norepinephrine coming from the adrenals. This is the after effects. So you almost get in a car accident, you get that quick response, and then afterwards you're like you're still on that high. Okay, that's the circulating epinephrine or adrenaline and all that stuff. So epi is basically some effects of the cardiac muscle as norepi, increases heart rate contraction. All right, to improve contractility, we increase heart rate. When we do those two things, what do we do to our cardiac output? Increase heart rate, increase contractility. We increase cardiac output. We're trying to increase cardiac output because what are we trying to do? Are we trying to sit on a toilet and have a bowel movement, or are we trying to get the heck away from the tire that's trying to kill us? Okay. A little bit of diarrhea as you go. Okay. Epinephrine does a whole bunch of things. Again, it constricts the blood vessels to the skin. This is where you get your paleness. It activates the coronary blood vessels, so you get more blood going to them. So you get more. Again, those muscles need the oxygen so that it can do its job and get you the heck out of there. Norepinephrine is just similar to epinephrine. It's actually the precursor to epinephrine, and it helps stimulate the cardiac muscles. I'm glad that's on audio. All right. So, any questions about anatomy physiology? Good reminder. Okay. Things that we have forgotten. Christmas past, Christmas present, Christmas future. So, things of Christmas past. All right. So, sample. What's the sample history? Okay. All right. So, for chest pain, what do we want to ask? Or someone that's having cardiac problems? When did it? Okay. 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 What else do you want to ask besides what were you doing? Do you take anything for it? Okay. What about constitutional symptoms? What do I mean by constitutional? What? So other symptoms. So they're just not having pain. So what's correct? Are you nauseated? Are you short of breath? Are you having diaphoresis? Some of the questions that kind of sort of when we talk about later with DVT and PEs and stuff like that. Did you travel anywhere? Do you take estrogen? Are you on hormonal replacements? Have you been to Africa with Ebola? If they bleeding? Okay. So past medical, of course, you know, eh, prescription medications. Do they have cardiac meds? Are they on beta blockers, which is a lot of people are on now? Are they on the Plavix if they've had a heart thing, or the new Effient and all that stuff? Are they being treated for any other illnesses? For the aspect of kids with myocarditis, had they had any upper respiratory infections recently? So the kids that are shortness of breath and like pale and they're like look like a CHF, ask mom and dad have they had an upper respiratory infection? Previous MIs, coronary bypass, do they have an AICD in? Have they had heart failure before, diabetes, lung disease, and all that stuff? Okay. Of course, we talked about allergies, AICDs, and then risk factors. All right. Classic presentation. All right. They have discomfort, lasts for more than 30 minutes. and they have associated signs and symptoms, your apprehension, the diaphoresis, the dyspnea. Dyspnea is what? Short breath, difficulty breathing, okay? And then the impending doom. They know that something's going to happen. And they're 9 times out of 10, they're usually right. All right. So your initial 30 seconds, again, this is your PAT, okay? Or the changing it from the pediatric assessment triangle to the patient assessment triangle. All right. Open the door. What does the patient look like? All right. Do you want to stay and play, or do you want to load and go? All right. Level of consciousness. How to level of consciousness? What? Okay. So what's AVPU? Okay. And what's the 3 parts of GCS? Okay. So different things. Respiration rate, pulse ox, or pulse rate, blood pressures, and or pulse regulators, and then all blood pressures. And those 3 things, how should we initially get them? Those should all be manual. Correct. Don't use any of the cardiacs. Exactly. So look, listen to the field approach, kind of sort of going from here. Look at the skippers, look for JVD, 45 degrees. Can always be a little bit problems with obese patients. Cap refill, what's the normal cap refill? Okay. Look, do they have any edema going on? If they're bedridden, looking at their ankles, or sometimes the cankles that some people like to call. Looking at the buttocks region and all that stuff, pitting versus non-pitting, you push down, does it come back up? Or the pitting, do you push down and it stays there? You can. You can have pitting edema in the butt. Yeah, yeah. Do they have anything, nitro patches? I've had several patients come in before that they kept passing out. So, no, more than that. Literally took the shirt off they were just covered with nitro patches because they forgot the one part of the instruction: remove previous. Yeah, yeah. So thank you for taking this consideration. So always look at the chest, remove the chest. Yeah, yeah. Well, remove the clothes off the chest so that you can look at it. All right. Do you have any medical alert bracelets and stuff like that? So what are we trying to listen for? What? Lub dub? The lub dub is what? Okay. Valves opposite closing, so that's the S1, S2. Listen to, yes, your great rhythm clarity and all that stuff. Okay, then when we talk about some stuff with the pulsus paradoxus, putting your shirt on, excellent. Don't forget about your lung. Don't forget about your lung sounds. Okay, specifically from the what lung absent lung sounds is not good. It, yeah, the lungs are not bad. The heart failure. Okay, with the bronchi and the rails and all that stuff, and then your heart sound. Okay, pitch, loudness, intensity, duration, timing, and then we talk about the S1, S2, S3, S4. All right. So auscultating the heart, ideally you should do it in 3 different positions, them sitting up, them lying flat, and then left lateral decubitus. Basically, from there, you're kind of sort of trying to the apical pulse or the PMI, pulse of muscle the point of maximal impulse from that aspect, which is usually the apex. So the four parts or the four valves, so the aortic, the pulmonic, the tricuspid, the mitral or bicuspid. So all physicians take money, mnemonic and all that stuff. Heart sounds are aortic versus the pulmonic, intercostal spaces. Again, if you're looking up here, second intercostal space, the right, the sternal, and then the tricuspid. Down here at the fifth intercostal space, and then fourth, fifth, just between the sternal and the nipple, and then underneath the nipple in your fifth or sixth intercostal space, depending on if they have pendulous breasts and all that stuff. S1 is the first part of the lub dub. Pendulous. All right. I knew. Yeah, just open that door for you guys. So S1 is the closing of your mitral and tricuspid. So we have atrial systole, okay, contract down. Actually, the end part of the dub, or from the dub to the beginning of the lub. Okay, so the atriums contract, push the blood through. They relax during the atrial diastole. The ventricles contract, and that forces or that makes the S lub. The dub is when the ventricles relax, and the aortic and pulmonic semilunar valves close. Of course, ventricular systole, or the start of ventricular diastole, which in turn is just immediately followed by your atrial systole. The S3, this is getting into your Kentucky, when the aspect where you have some extra filling or the fluid sound, usually based at the apex. When we hear this over the age of 30, start thinking CHF. So the heart sound is actually Kentucky, 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 which is a very prominent. If you have a CHF patient, you know they're a CHF, like Florida CHF, really listen, at the apex of the heart and all that stuff. It's actually quite interesting. And then S4 is the Tennessee. This is when we have the atrioventricular or your bicuspid tricuspid valves. Usually it's more on the tricuspid is the major one. Becomes stiff, and it has to crack open to be able to get the blood flow. So you get the S4, which is the tent, and then the C. Tent, the C. Tent, the C. From that aspect. Don't hear that one that very often. Okay. So field side, peripheral, thicodemas, pulse, again, going through the regulators and all that stuff. What's pulseless paradoxus? It is. Okay. So pulseless paradoxus is where you can hear a heart sound, but you cannot feel a radial pulse. All right. The normal thing that anytime that we breathe in, our blood pressure will drop down, usually less than 10 millimeters mercury. But when it drops more than 10, you can actually have problems in having your distal pulses and all that stuff. So things like cardiac tamponade, COPD patients, that's what that will cause pulseless paradoxus. And then the pulseless alternans, not yes, no. So it's alternating. So you get weak pulse, strong pulse, weak pulse, strong pulse, weak pulse, strong pulse. And this is another telltale sign for with cardiac tamponades. What happens is you get a lot of the blood filling, the heart pushes over, and it and then the fluid that's around in the tamponade prohibits the ventricles from filling, and then it takes a couple beats for it to fill, and then it's able to contract again. Mm-hmm. Well, not so much a clot, so I stab you in the heart, I shoot you, something like that. Or end-stage renal patients where they have tamponades, they miss dialysis. PMI, the place, if you feel your chest wall, where do you feel the heartbeat? And it's coin size, should be right below the nipple, um, in the mid clavicular line. Have the patient's left out of the decubitus position, all that stuff. All right. So, any questions on anatomy, physiology, history, physics? Right. So the next little while will be some different diseases. Quickly run through all this and go from there. All right. So hypertension is usually anything over 100, 140 over 90, just by definition. Multiple different how the patient kind of sort of feels. The chronic hypertension can cause multiple things that we know: strokes, renal failure, MIs, and then the dissections that we'll talk about a little bit later. Hypertensive emergencies. This is where they have end organ damage. So their blood pressure. Traditionally, what is with hypertensive emergencies? What do you see their blood pressure? Or when do we start getting concerned and really worried? What's the value? 200? Okay. So yeah, 180 to 220, something in that range. Actually, I had a patient the other day had a blood pressure systolic of 247. Yeah, exactly. Yes, he was. What? So things again, when they're having hypertensive emergencies, and ask them, are you having headaches? Are you having any chest pain? Are you having any difficulty peeing and all that stuff? Which of course that's all end organ damage stuff. MI, dissections, edemas, hemorrhages, toxemia you can get from this with your from pregnant patients. Okay, so your preeclampsia and eclampsia with toxemia can cause the elevated blood pressure, and then ultimately with the hypertensive encephalopathy. Signs: they become short of breath, EKG changes, they have the LVH on the heart or on your EKG, nosebleeds, headaches. So in the epistaxis guidelines, it's sometimes you have to really lower their blood pressure down before the nosebleeds will go away, especially if they're on Coumadin and Plavix and all that stuff. Are they having ringing in the ears with tinnitus, vomiting? So the encephalopathy, basically the brain itself becomes hyperperfused because there's too much blood pressure going on. You destroy the blood-brain barriers, all the bad chemicals inside the brain, and encephalopathy is basically irritation, inflammation of the brain itself. So it gets screwed up. Too much fluid inside the brain, and you go from there. Bad problems with encephalopathy. They start off with plenty of headaches, nausea. They can have problems speaking, paralysis, blindness, and then ultimately it's really to lower the blood pressures treatment-wise. So for your medics out there and all that stuff, law is the first drug. Can't use nitroglycerin. So for you guys, if even though they're having heart attacks, chest pains, and all that stuff with elevated blood pressure, using your nitroglycerin and all that. So with atherosclerosis, okay, it's a disease process. They usually say that by the age of 10, we start having some atheromas or plaques. The more, and there's hit or miss depending on what type of foods that we eat. Some they say if you eat high, you're a lot of lipids and fats and all that stuff, you can potentially have it. They're saying now it's just more of a genetic issue. Really, it varies. The biggest though is usually at the branch points or the bifurcations of the blood vessels is where you develop all the atheromas in the sclerosis. All right. So what's the major concern or the problem with atherosclerosis or with these atheromas? It says in there about the turbulent blood flow ultimately leads to what? Cardiac failure because can't move the blood. Exactly. All right. So side effects disrupts the intimal surface, and then the atheroma itself reduces the diameter of the blood vessel size. And then ultimately they have some other, mitigating factors. They just hit the jackpot and woohoo, they get all this everything clamps down, and then they have a heart attack and die. Chief complaint, the chest pain or discomfort. We talk a little bit about angina in a little bit. Then from there, you can also have your dyspnea or your syncope. Ultimately, this leads into your typical classic anginal type stuff. So, angina pectoris is actually the term angina, or angina is to choke, which is Latin from anger. We actually do not have enough oxygen to supply the heart itself. So anytime back to the physiology, for remember you guys, from the aspect, the one thing that you can really help with in how much oxygen or how much the heart is specifically related to how much oxygen it has. So giving the patient some extra oxygen, keeping the patient calm down. This is why for the medics and all that stuff out there, using Versed or one of the benzodiazepines kind of sort of helps calm them down, and you can actually help out, with STEMI patients. So stress, increased oxygen demand, coronary arteries can't dilate enough to get the oxygen there, and then you develop the anginal pectoris or the chest pain and all that stuff. Symptoms, the classic left-sided chest pain radiates to the neck and down the arm, and this is all because of your embryologic, how the nervous system is made up. You get pain, substernal, you get the crushing, heavy, stabbing, all that stuff, radiates, and then, of course, your shortness of breath, nausea, vomiting, sweating, and all that. Your classic symptoms. Okay. Do with exercise, with eating, okay, and then emotion with the stresses and all that. And then typically lasts greater than 30, and can be relieved by rest or nitroglycerin. So if it's relieved by rest, what is it the angina? What type of angina is it? You guys heard the two different types? Stable versus unstable? Vaguely sound familiar? No? Okay. So stable angina is you exercise or whatever, you get the chest pain, you stop, you sit down, chest pain goes away. That's stable. So if you're doing your exercise, you're eating, you're having intercourse, whatever, you get the chest pain, you stop, and it's still there after 30 minutes, that's unstable. And now they're really saying that unstable angina is almost they're having a STEMI and a heart attack and all that stuff, or they're having a myocardial ischemia and infarctions. Fear, okay, they have problems with fixation, pale, ashen, livid, short of breath, From there, they have nausea, diaphoresis. They have some blood pressure issues, and then the dysrhythmias. All right. And what's the major dysrhythmia that we get concerned about? All dysrhythmias end in what's the terminal dysrhythmia? Asystole. So prior to that, all right, why do we use AEDs? Jumpstart. What's the arrhythmias? What's the dysrhythmias? Can't you use AED? Can't, yeah, yeah, VFib, VTAC. Those are what it's getting into. I don't know how many times I've had patients come in, and we all seen this STEMI patients, and then they have, they go into VFib, VTAC arrest. All right. An angina, it's really an anginal itself, or they have just an anginal equivalent. They don't really have much damage to the myocardium. Right, this is the aspect of they're just having the ischemia. They're not having the actual infarction itself. That was gonna fill Viagra. Yeah, it's actually quite interesting how they came about with Viagra. So they gave it. They were doing it at the VA. And it was an astute nurse that was asking some of these gentlemen questions, and they all kept asking. They kept making comments that they were having erections, and she just made comment to the doctors, and that's how it became a multi-billion-dollar. Could have been. So different forms. Again, the stable, which we talked about, occurs with exercise, predictable, relieved by nitro and rest. And then the unstable, which is the more frequent, severe rest. And this is the aspect of impending MIs. All right. From the heart attacks, pretty much what it is, or the myocardial infarctions, we don't get enough oxygen to the heart. From there, damage to the myocardium, which is a bad thing. You have the ischemia, and then ultimately the death of the myocardium, which is the infarction. So ischemia is damage, which we call ischemia, or the aspect of the infarctions and all that. So symptoms, what do patients look like? Pending doom. They're sort of having chest pains, diaphoretic, short of breath. Okay. What are they complaining? How's the chest pain? Substernal, can be. Someone sitting on the chest, elephants rising. 85% substernal, crushing, squeezing, tight, heavy. Okay. And then from there, also complaining of radiation, intensities, you know, swallowing doesn't help or doesn't do anything, coughing, deep breathing, movement. It's just the pain is always there. Unrelieved by rest and nitro. Sometimes, nitro will help, but not always. Longer than 2 hours. Oh, sorry. Um, Up to 12 hours, which is the typical. And then you have the silent MIs, which is your 15 patient or your 50%. This was what my aunt had, silent MIs. Elderly, diabetics. This is why typically all diabetic patients complaining of chest pain should go or be evaluated and treated. Other symptoms, short of breath, you're weak, dizzy. Again, your nausea, vomiting, pale, diaphoresis, impending doom that you guys talked about, denial, males, most common. Okay, what do we say it is? What's the cause? Ingestion, heartburn. Wait 3 hours, and then, of course, changes in your pulsus paradoxus, pulsus alternans, all that stuff. What are we trying to prevent? Okay, we're trying to prevent the heart attack, but why do we want early recognition? Correct. Yep, we want to decrease tissue damage. All right, and for you guys, what's the number one therapy? Oxygen and aspirin. Okay, everybody gets the life-saving aspirin. It's actually theoretically, or it's been proven that's the only thing that's been really beneficial, except for getting into the cath lab and all that stuff. Dislocations, just from the aspect size of the infarctions, really depends on the metabolic demand. Again, getting the patient to calm down, giving them oxygen, really it helps from that aspect. And then the duration of the time and the flow. And this is why the American Heart Association and all that stuff, it's no longer door to balloon time. It's now provider balloon time. Okay. And provider is not the doctor, it's you guys. Okay. The clock starts when you guys, as EMS providers, first touch the patient. Left ventricle, of course, just from the aspect of, again, going back to the LAD, the left coronary, that supplies the major part of the heart, which we know. And then different sides of the heart where you can look at the septal walls, inferior walls, and all that stuff. And then the problems with the inferior wall infarctions from the aspect of the coronary arteries, including the coronaries. Treat it, oxygen, reestablish the ischemia, getting them to a cab. Can't throw a cat in any direction in this area without hitting a cath lab, which is a good thing for us. And then calming the patient down, giving them Versed, Valium, Ativan, anything to really calm them down. Death, VTAC, VFib, your dysrhythmias, of course, cardiac standstill, your asystole, pump failures, they can go into cardiogenic shock, CHF, which we'll talk about a little bit, and then the disruptions of your chordae tendinis and papillary muscles. Questions on heart attacks? That's never a good thing. Yep. So dyspnea and syncope. Dyspnea, again, is just the shortness of breath, multiple different things that cause it. Don't think always about the heart when they're having dyspnea, COPDs, respiratory infections, PEs, again, so if they're complaining of chest pain, shortness of breath, questions that you should really ask. Have you had recent travel? Okay. Have you had recent surgeries? Do you have previous blood clots? Do you have any, weird genetic things, factor V Leiden deficiencies, stuff like that? Do you smoke and on estrogen? That's a very common thing that I see a lot of times. And then just the durations, aggravating things. What's all the the previous episodes. What's orthopnea? What? Okay. Orthopnea is shortness of breath with laying flat or position. Okay. And again, that's when we a little bit further when we talk about your CHF patients. So they're laying flat, the blood, everything kind of sort of pools, all the fluid goes into the lungs, they become acutely short of breath, and then they have problems. What? Yes. Syncope, of course, is any time that we have a decrease in the brain. Okay. The brain doesn't like it. It doesn't get oxygen. What does it tell the body to do? Shut down, and you fall. Hence the person there. All right. Different type of cardiac disorders. Your the aspect of your vasovagal episodes and all that stuff. Your people with SVTs can sometimes have this. All the dysrhythmias. They can have syncopal episodes and all that. From the aspect, also be caused with strokes, drugs, and alcohol. You've been out partying, you're dehydrated, use a little bit too much cocaine, aortic stenosis, or the aortic valve itself when we get old, it basically doesn't work as well, so blood flow can't get through. So then we decrease our stroke volume, decrease our cardiac output. Questions, all the typical things. You know this. You guys probably do a very good job here with people that syncopize. You probably have a couple of them here. Well, it's not your first rodeo. Palpitations, pretty much anything from the aspect of different dysrhythmias. Um, they can have get your pulse rate. Is it regular versus irregular? For your atrial fibrillations and stuff like that. Are they having other signs and symptoms? Did they drink a whole bunch of caffeine beforehand? They're monsters, the Red Bulls and all that stuff, trying to stay awake for an 8 a.m. lecture. You can do all the palpitations from there. Are they doing different drugs? Are they doing their K2? Are they doing their bath salts and all that stuff? LSDs. Starting early. All right. So LVH, or your failure, and then also the edema side of it. Uh, So on the heart failure, again, remember that the left ventricle is the most common form of heart failure. Okay. And right-sided heart failure is typically caused by, I'm sorry, let me go. Left-sided heart failure is typically caused by what? What? We'll back up from lungs. That's some signs and symptoms. What's the cause of it, though? What causes heart problems? Right? Lack of action, all that stuff. So stuff like your COPDs, when we get into core pulmonary, your diabetes, your high blood pressure, smoking, all those classic things. Okay. So usually your left ventricular is the most common, is usually your hypertension, diabetes, and all that stuff. All right. And then the most common cause of right-sided heart failure is not so much electrical, it's actually left-sided heart failure. Okay. So they lose their ability to contract, which in turn goes into the lungs. They can no longer push to the right. The right gets pissed off and says, "Oh, I give up." And then that's how we get the swelling in our legs and all that stuff from the right side of the heart failure. Different varieties. You can have heart problems, valvular problems, hypertensive heart disease, and then untreated leads to pulmonary edema, which Renee's saying from the aspect of backing up into the lungs and all that stuff. That's where we get our pulmonary edema. Signs and symptoms: shortness of breath, apprehensives, your cyanosis, the JVD. Okay. And for you guys, what's the treatment? Action. What else? What? Elevate. What else? We need to do some guideline review. What can you put on them? Mask wise. What? The spring, not. Yeah. All right. So if they're, yeah, yeah. So the rescue guard doesn't always, and actually there's contraindications with the heart failure, pulmonary edema using the rescue guard. Because it has problems, or actually causes more blood flow coming back to the heart. Right? So we don't want to use the rescue guard, but what's something that looks like the rescue guard that we do want to use? CPAP. Okay, so you CPAP and all that stuff. CPAP increases the amount of volume in the lungs. When I decrease volume, I push the air out. I'm going to talk about this a little bit too. Okay, push the air into the lungs, pushes the fluid out, and it preload because now you increase the volume in the lung, and it stops the blood coming back to the heart, which in turn decreases your cardiac output, which helps. A whole bunch of pathophysiology. Again, just like the right failure, the right side of the heart gives up, says, "Screw it, I'm done." All right, doesn't like what the left side was doing, and then you get backup of blood into the systemic side. Different things, hypertension, of course, COPD. Seen a lot of patients with having PEs or blood clots that they have the right side of heart failure, and then the most common RVF is secondary to LVF. Tachycardia, again, peripheral edema, all those things, the typical, the non-lung sounding CHF stuff, swelling to the feet, your kinkles and all that. So two different types of dysfunction, just briefly, reminding you guys here. You can either have systolic dysfunction, and this is where you get the big floppy ventricles. Okay, so this is the most common form of your CHF dysfunction or congestive heart failure dysfunction, where this would be like your alcoholics, your myocarditis, infections, and all that stuff, versus your systolic dysfunction is where the ventricles become really enlarged, okay, and you don't get a lot of blood. So if I can't get a lot of blood into the heart, thereby it can't do the stroke volume. I decrease stroke volume, thereby I decrease our cardiac output. Versus this one here is I get a whole bunch of blood, but I can't contract and I can't push it out, so I decrease contractility, thereby decreasing stroke volume that way. That's why it's important from the aspect. So on systolic, we pump less, the heart's not working. And then versus dystolic, we actually fill less, which is the important because, again, both of those affect our systolic or our stroke volume. All right. Ultimately, in turn, medications that we use and all that stuff kind of sort of helps with this, depending on which way. Cardiogenic shock, this is just the most common form or the worst form of heart failure. This is where the body really just says, "Screw it, I'm done." All right. So they have heart failure, signs and symptoms of CHF, and then low blood pressure, shock-wise. And therapy, for the most part, here is getting them, treating them, giving the pressors, your dopamine, norepinephrine for the paramedics and all that stuff. All right. Now, you guys kind of sort of didn't remember, but I did include. All right. So CPAP, 10 centimeters is the starting dose. From there, you guys can, if you have access to EKGs, as long as you don't delay care, and you can transmit. That's the guidelines. For the paramedics and advanced EMTs, so from the aspect, so you're out and about, not here. Cardiac monitors get IVIO access. If they're low, using your dopamine, norepinephrine. If their blood pressure is still above 90 and they're having signs and symptoms, giving them nitroglycerin, 0.4 or midazolam, 2 to 4 if they're really anxious. Captopril or nalopril for the medics. And then 30 to 60 minutes after being on nitro is when we give Lasix. So you guys, for the most part, in the field, aren't really giving Lasix, and most departments aren't carrying Lasix anymore. that gets the fluid off. So for the EMTs, setting them up, high flow, oxygen. Now, if they're already satting, 95, 96, 97%, okay, you don't need a lot of high flow oxygen. All right. Again, the conversation that we've had in the past from the aspect of too much oxygen can actually be detrimental. So from there, it's really just using more of your CPAP, maybe little supplemental oxygen from that. And then for the paramedics, we're trying to decrease the heart, the load, and all that stuff. So on the CPAP, just the indications. Again, COPD, awake or CHF, pulmonary edemas, drownings, over age of 12 or 40 kilograms, just so that they can fit the mask. Contraindications, they can't supply it. They've been vomiting, tracheostomies, and then facial anomalies. And this is just the CPAP. From there, what the purpose of CPAP is, continuous positive airway pressure. It's really when blowing up a balloon, what's the part? That initial, okay? So what this does is it acts as a little pillow or a buffer, so it always keeps the balloon open. So anytime that you take a deep breath from there, it's not having to really push down, or you don't have to work as hard to open all the alveoli. What we need, this is the old style from the aspect of the old whisper flows, which is the gray thing, which is shown in a second. And then the other aspect of your PEEP, which is your positive end expiratory pressure. This is the little valves that, again, help keep everything open. On BVMs, you can use a PEEP, or you can get a PEEP valve. But in a couple slides, when we talk about the pulmonines, this is what you're dialing in and how much. So old trends, this used to be the old whisper flow generator, which no longer have that. Everything is going now more into this line, or into the aspect with the pulmonines, where the whisper flow, the flow generators, and all that stuff comes from there. And this is your PEEP valve. All right. Comes in 5, 7.5, and 10. All you do for you guys is just screw it in. And you can dial into how much PEEP you need. So CHF, just go straight to 10. Put the mask on and go from there. I know that some of the departments are using the flow saves. It's really, you actually develop how much PEEP by how much flow that you have going through there. The flow generators and all that stuff is built into that. Again, just from the aspect of your valve settings, and go from there. So for the ALS, use a nitro, trying to get them up to 100. Afterload helps with the nitroglycerin, ACE inhibitors, the nalopril and catripil. And in 30 minutes, at a rate of at least 40 mics of nitro, then you give Lasix, and that helps get the fluid off the heart. But for you guys here, just getting them on a CPAP, you can change, you guys have the quick with Life Squad 2 coming over and all that stuff. So how does nitro work? Acts both for angina and then for CHF, pulmonary edema, to get the fluids. We know it's good for MIs and high blood pressures. That's also been used for the anal fissures. What it does is actually gets nitric oxide into the body from this whole aspect of conversions by the mitochondrial aldehyde dehydrogenase, which in turn allows for the smooth muscles to relax, which in turn, from there, going back into the capacitance vessels, you dilate all the venous side and make more parking lots, okay, so I can put more cars into the parking lot. And then 40 mics is the ideal dose for the pulmonary edema. Sprays, IV concentrations, just kind of sort of skip over that for you. Titrate for the paramedics and all that stuff. Does cause hypertension, headaches. We know this. From there, it can increase the heart rate because of the drop in blood pressure. And then problems with zinc and copper stores. That's why they say that patients on nitro patches, they should take the patch off for a time period so that they can replenish their zinc and copper stores. The other for the paramedics, getting in the whole process of angiotensin. So with CHF, what happens is the kidneys they don't have a heart rate volume, or they can't see blood pressure, so they release a chemical called renin. Renin goes to the liver, basically converts angiotensin into angiotensin 1, and then angiotensin 1 goes to the lungs, where it's converted into angiotensin 2, which causes all these problems. Increases the heart rate, causes blood constriction, circulates back to the kidneys and tells the kidneys to collect water, and that's how it's the cyclical effect of CHF. It retains water, and then you can't get enough blood pressure, and you build up more water, it retains water, and all that. And that's where the ACE inhibitors come into play. So you have lisinopril, enalapril, captopril, and all that stuff. And it reduces the blood pressure. Chronic treatment, pretty much from the aspect medication, digitals, diuretics, get the fluid off, keep it off. Diet modifications, exercise, lose weight, all that stuff. Right. Last piece on this, and then we'll switch into some of the other tamponades. This is anything that causes fluid around the heart. I shoot you, I stab you, dialysis, anything that really impedes the blood flow or the heart from being able to move fluid and all that stuff. Different causes that we kind of sort of just already talked about. Impending dooms. This is like also JVD or the triad. The muffled heart sounds, JVD, and hypotension. Really for you guys, is getting them to the hospital. Okay. Questions on any of that? All right. A couple different things, just for the other cardiacs. Dissections or aneurysms. So the thoracic dissections, basically the dilation of the blood vessels or the tear and the ripping. This is the Three's Company. What's his name? Yeah, Jack Ritter. There's how he died. Okay, or the author for the person that wrote Rent. Yeah, I can't remember his name right offhand too. So genetics, Marfan syndromes is a huge thing. Atherosclerosis, infections, primary syphilis. This is why you should get your syphilis taken care of. And then usually the cause of you get on scene from a car accident and the patient's dead. They've had the traumatic their aorta tore. All right, that's usually you're not much you're going to do with that. Signs and symptoms: they can just get the leaking. They can have low blood pressure, heart rates, or that's the management is really if they have dissections or aneurysms. We want to get their heart rate and their blood pressure as low as we possibly can. Okay, and for the medics and all that stuff, it's usually labetalol or metoprolol, enough until they can barely maintain consciousness. Heart rate into the 50s, 40s, blood pressure into the 80s and 90s, and then transporting them very quickly to a hospital, surgically corrected. Different types of branches, whole bunch of things if you've never really seen all the things come off the aorta. Just going to skip over that. How the aneurysm occurs, going back into our the atherosclerosis or the atheromas. They get into your plaque formation. From there, you have the intima in the aorta, kind of separates from the tunica media or the middle portion of it. Blood then gets into that, and you start building a new pathway. And then ultimately, you have two separates between the intima or the media, and then the last one, the tunica vesselalis or the lateralis, that's what tears open, and now we have a complete opening of the aorta. Occlusions, different causes and all that stuff. MIs, study of occlusions of ischemia, which in turn has problems. All right. This will be like your PEs, your DVTs, and all that stuff. Pain, pallor. They get the unilateral leg swelling. They've been on long trips. They've had different clots. They've been in a trauma before they develop the DVTs, capillary refill problems. All right. So different sites of your embolic occlusions. Of course, if we get it up into the carotid arteries, what do they have? If we occlude the carotid arteries, what do they develop? Stroke, TIAs, all that stuff. If they have stuff down in the DVTs, they can have problems with the legs. If it gets into lungs, of course, that's the pulmonary embolisms and death. The venous thrombus, history of trauma, sepsis, infections, pregnancy is a huge thing, birth control, and smoking, cancer, and then varicose veins. That's why if you're on your feet long periods of time, if you should be doing ankle pumps or wearing the stockings if you have varicose veins. Risk factors, occlusions, all that stuff. Okay. And then the atherosclerotic occlusive diseases, different places. Usually any bifurcation. All right. PA, this is just the aspect of pulseless electrical activity. So they have a electrical, but they don't have mechanical. So again, going back to the pump and or the engine. Okay, you can start the car, but the car just won't run. And here, ultimately, different causes for that: correctable pneumothorax, acidosis, enough oxygen. They have a lot of times your dialysis patients with high potassiums, drug overdoses, your opiates and all that stuff. And then the less correctable MIs, profound volume loss. So your trauma patients, when they get into the irreversible shock, and then PEs. I've had, unfortunately, a bad run of PE recently. Patients dying and all that stuff. All right, just a little bit in the aspect of how to manage the cardiac or CPR and all that stuff. If you think about everything that we do, it's really continuum. The way that healthcare is going in the future, we'll be doing at-home checks on patients in the near future. Exactly. Maybe not for you guys here, but paramedics. Yeah, the whole paramedicine thought process. So everything from prevention to care, dispatch, BLS, ALS, ED. We got paramedics in the emergency department, rehab, and then ultimately you guys will be checking on the patients at home. Are they doing things properly? Managing cardiac, it's really, BLS. I don't care how well we do ALS. If we don't do BLS well, everything else sucks. I don't care what medications you want to carry and all that stuff. If we're not doing good chest compressions, CPR, mechanical CPR devices are becoming the mainstay therapy now. So a lot of departments are carrying and all that stuff. Mm-hmm. What we're trying to really do is we're trying to prevent ventricular fibrillation. For the BLS side of it, you're not restarting the heart. You're really in the aspect of getting enough blood circulating until you can get a defibrillation, and then from there, that will help. So most effective form of VFib or VTAC is electricity. Let them ride the white lightning. All right. VFib time increases or decreases survivability. So every minute they're in VFib, 10% of decrease in chance of survival. All right. So if you think about it from the aspect of most of our calls, how long does it take us to get there? 5 to 7 minutes. So there are 50 to 70% chance of not surviving. That's why bystander CPR is so huge in early defibrillation. Basically, like, not much that we can do we're not convert it back to normal sinus. What we're really trying to do is just buy time so that we can get the defibrillator there. All right. Should be trained and operated. If you don't know how to use your AED, make sure you go back up, pull it apart, look at it, make sure everything's working. Monthly checks. CPR devices, different things, eliminate rescue fatigue. We know that from the aspect, fatigue starts at about 90 seconds, even though the AHA says switch every 2 minutes, or the Red Cross every 2 minutes. We suck at this, especially when we start transporting patients. Once we start transporting, we drop the ability down to about 17% effectiveness. These things, they work. You can almost get a heartbeat from a turnip. Defibrillation, the whole aspect here is we're trying to stop the heart and then let the pacemaker kick back in and take over, or something within, that acts as the pacemaker. Basically, stop it all at once and then kind of sort of go from there. So depolarize everything at once. Early defibrillation helps with cardiac arrest. We know that's the major thing that for therapy-wise. And then multiple attempts diminishes over time. So we know that once or twice, if it doesn't work, the possibility of getting them back is usually not good. AEDs, analyze. Usually they're foolproof. Put the pads on and hit the button. Let it analyze. Hands off, and then they'll tell you to shock or defibrillate and go from there. Excuse me. Different pad placements. Some still like the anterolateral. I still kind of sort of prefer the front back method, or your anterior posterior, where you can really, from the aspect of capturing. There's some now that are even doing what's called double shock, where they're having two Lucas devices at the same time, and they'll put pads both in the anterolateral, and they'll hit one and then hit the other. Exactly. They're really, two of the Life Pack or Zols and all that stuff. Thanks for the correction. Remember to the second slide. Things I said. Lack of sleep. Whole purpose of that is really the devices, they have energy, and then they deliver their stored energy, and really from the aspect of trying to, again, stop the electricity in the heart so that it can kind of sort of recycle and go from there. The defibrillator, different things from the aspect, different manufacturers, and go from there. Whole purpose of that is really you can either defibrillate it with the machine, or they can even pace it using the Zoll X's, your LifePak 15s, 12s, and all that stuff. Biggest thing for us for safety-wise, make sure that you don't do it while someone's touching them. That's always a bad thing. And then from there, contact. I've actually seen some doctors actually put their hand on the defibrillator pads because they say it works a little bit better. Special events or special places, ideally you can't defibrillate them in a pool, get them out of the rain, all that stuff. And metal roofs, they've actually, there was a question a couple of years ago that they had a cardiac arrest on one of the fire department's roofs that was metal. And then there was the whole thing about can we use it, can not use it. Ultimately contacted the manufacturers and like, yeah, you can. Just make sure that you're, outside of 1 inch from the person. It doesn't then transmit. AICDs, or your implantable devices. Basically, the whole purpose of this is it monitors the patient, and then from there, if it detects something, it does one of a couple things. One, sometimes it does what's called overdrive pacing, to get them out of the arrhythmia and all that stuff. Ultimately, when do we quit? What's the guidelines for quitting? Asystole, okay? Or your AED does not advise a shock. Okay? So you don't always see asystole with the AEDs. What else? Yep, DNR, physically exhausted, just got the paperwork. Okay? How long should you guys at least attempt to work the code for? What's the guideline say? 20 minutes? At least 20 minutes. All right. And go from there. And then that's it. Any questions?